Good evening, everybody. Thank you for joining us. We're glad you're here. My name is Blake Obrock. Before we get started, I'm going to tell you a little bit about me. I am the newest member of the NAO team. I'm board certified in orthopedic surgery and fellowship trained in sports medicine. My practice is focused on comprehensive care of the shoulders, knees, and sports injuries. I see patients in our Flagstaff and Prescott Valley clinics. I am an Arizona native. I grew up in the Phoenix area. I did my undergrad at Arizona State University and my medical school at Midwestern University. I moved to Oregon for my residency and I did my fellowship at the University of New Mexico. Prior to joining NAO, I was practicing for several years in Texas. While I was there, I was the medical director for a sports physical therapy rehab program, and I had a community faculty appointment at Texas Tech University. In my career, I've been able to take part in several organizations, but my favorite is this one. This is my family, my two little girls, Ella and Riley on the left, my wife, Jenny on the right. And we are happy as can be back home in Arizona. Before we get started on our topic, I want to cover a little bit of anatomy and some of the imaging that we use to help you better understand the topic. The first picture on the left is a view straight on of the knee. This structure at the top is the quadriceps tendon. This is the patella or kneecap, and this is the patellar tendon. This view on the right is the same view, but the patella and tendons have been removed. We're looking at the four major stabilizing ligaments of the knee. This is the anterior cruciate ligament. This is the posterior cruciate ligament. These are called cruciate ligaments because they form a cross. The lateral collateral ligament and the medial collateral ligament. In a healthy normal joint, there is a very slick white cartilage at the end. This is the same stuff that you see at the end of a chicken bone. It helps our joints to glidely smooth over each other and helps distribute nutrition to the joint. When that cartilage becomes damaged, we start to get fissures or cracks in the cartilage. The bone underneath the cartilage is exposed, which causes an inflammatory response, and the nerves there become irritated. That causes the characteristic pain associated with arthritis. Whenever a new patient comes in and has complaints of knee pain, I ask the same 7 questions. This really helps us to define what's going on and help figure out what the problem is. These questions include things like, where does your knee hurt? Did you feel a pop? Did your knee swell? If it swelled, how quickly did it swell? Does it feel stable? Does anything make this better or worse? The answer to these 7 questions gives me about 90% of the information I need to figure out what's going on with your knee. Several of those questions are red flags that we look for. So we're going to talk about a couple of those because they warrant special attention. The first is severe swelling. If you had an injury to your knee and within a few hours it swells up like a grapefruit seen here, that is a sign that something traumatic has happened in your knee. Similarly, the inability to bear weight or locking of your knee, if it gets stuck in one position or feels unstable, these are all warning signs that a substantial injury has happened inside the knee. Any of these things occurring should be addressed sooner rather than later. If you would call to schedule an appointment with us, these would be important things to tell our schedulers so that we can help expedite your care. Or better yet, come see us at the NAO Urgent Ortho Clinic. Oftentimes, if you come into the clinic, it's a walk-in appointment. It's a walk-in visit. There are no appointments necessary. We'll have you seen by one of our subspecialist surgeons. We can usually get an MRI if it's indicated that day and have a plan of treatment set up all within the same day. No visit to the orthopedic surgeon is complete without some form of imaging. The most common thing that we will do are x-rays. These are 3 common x-ray views. X-rays show us bony detail They don't do a very good job of showing us soft tissue, but we can infer a lot of information based on simple x-rays. This picture on the left is a normal x-ray of the knee. There is a space between the bones. It looks like empty space, but that's actually filled with cartilage. Cartilage does not calcify, so it doesn't show up on an x-ray. The image on the right is the same type of view of the knee, but that space is gone. That space is gone because there's no cartilage in that portion of the knee. There's also a very small little bone spur sticking up here, a little one over here, and a similar one over here. The overall alignment of the knee has also changed on this x-ray, and this is characteristic of arthritis. The next kind of imaging that we will sometimes get is a CT scan. A CT scan is a lot like an x-ray. It gives us excellent bony detail and some soft tissue. I often use CT scans to create very accurate three-dimensional representations of the knee that we use to make custom implants for knee replacements. The last and the favorite imaging modality of knee surgeons everywhere is the MRI. The MRI is helpful at helping us to see soft tissue. It does show us some bony detail like the CT scan, but its real value is the soft tissue. This red arrow here is pointing to the ACL. This green arrow over here is pointing to the tibial artery. And we can even see details like the integrity of the cartilage on the articular surface. This is an overview of some of the most common injuries that people present to an orthopedic surgeon with. Things that are bolded are what we are going to touch on tonight. Many people who are joining us tonight may have had or may know someone who's had a meniscus tear, but you may not know what the meniscus is. So let's talk about that first. Each of our knees has two menisci. They're C-shaped cartilage structures that act as a cushion or a pillow to the knee. They are a very effective shock absorber, and they help us distribute force throughout our knee. They deepen the articular surface to give us a more congruent joint, and they also help us distribute nutrients throughout the fluid in our knee. Meniscus tears can occur in a variety of different mechanisms. The most common is a non-contact or a non-collisional twisting injury. When you tear a meniscus, people typically have swelling that occurs. It doesn't happen immediately. It usually takes several hours, or sometimes you'll notice it the next day. And meniscus tears are characterized by a sharp stabbing pain that you experience worse with pivoting. One of the most common things people describe with a meniscus tear is pain that bothers them when they're getting into or out of their car. If a meniscus tear occurs and the flap of the meniscus tear becomes unstable, it can displace, and that can cause locking or catching in your knee. In the setting of a symptomatic meniscus tear, we often consider surgery. This is done arthroscopically using a very small camera that is smaller than a number 2 pencil. And it's put in through very small holes in the knee, and we're able to see all of the tissue inside the knee. This first view is an arthroscopic view of the inside of the knee. This shiny white structure at the very top is the end of the thigh bone. It's covered by healthy cartilage. The shin bone articular surface is right up here, called the tibia, and that also has very healthy cartilage. This tan structure that runs through the center is the meniscus. It's very thick out here on the periphery, and it comes to this fine razor's edge on the inside. This is what a normal meniscus should look like. This is a torn meniscus. This flap right here has come free from the surrounding tissue and has displaced. If you had a meniscus tear like this, when you would be pivoting or twisting or maybe climbing upstairs, you may feel this tissue pinch between the two bones, and it causes a momentary sharp pain. Most meniscus tears are treated by debriding or removing the unstable flap. This is the meniscus tear before, And this is the same knee after debridement of that unstable flap has been performed. We try and remove only the damaged tissue and leave the healthy tissue alone. Sometimes we will try and repair a meniscus. This is done to bring the edges of the meniscus back together and stimulate them to heal. You may be asking, well, why do you sometimes trim the meniscus and sometimes repair the meniscus, and how do you decide what to do? That depends on a variety of factors: the size of the tear, the location, the age of the patient, how active they are, the quality of the cartilage in their knee. These are all important factors. Probably the most important thing is the blood supply to their meniscus. These two pictures on the right help to illustrate this. This top one is a cadaveric specimen where an anatomist injected a dye called India ink into the blood vessels. That India ink goes wherever the blood vessels are. And if you look out here on the outside, you see this rich network of blood vessels. As we get towards the thinner inner portion of the meniscus, there is no blood supply. We give these names like the red zone for where it's very vascular. The red-white zone is in between, and the white zone where there is no blood supply. A tear out here has very little potential to heal, whereas a tear over here has excellent potential to heal. Next, we are going to talk about the stabilizing ligaments of the knee. This is that same picture we looked at before. It shows the four major stabilizing ligaments. This is the ACL or anterior cruciate ligament, the posterior cruciate ligament, the medial collateral ligament, and the lateral collateral ligament. When orthopedic surgeons talk shop with each other, we tend to use terms like posterior lateral corner instead of lateral collateral ligament. The reason why we do that is to say lateral collateral ligament is somewhat of an oversimplification of the anatomy. We like to think of it like this, but in reality, the posterior lateral corner of the knee looks something more like this. It's very complex and nuanced anatomy. For the purposes of tonight's topic, we're going to talk about it as if it was just a single ligament. The first and most common ligament injury in the knee is the ACL, or anterior cruciate ligament. This is most often a non-contact pivoting injury, similar to meniscus tears. 70% of people that have an ACL injury will hear or feel a pop in their knee when it happens. Often the people immediately around you will also hear the pop when your ACL tears. People get severe swelling in their knee. It occurs very quickly within an hour or two. Your knee will feel unstable almost immediately, and often people have a hard time walking immediately after this. ACL injuries are more common in females than they are in males, and skiers more often than snowboarders. When people tear their ACL, they usually are in this very characteristic position. The soccer player on the right here is highlighting this very well. He kicks the ball, he plants his foot, twist, and his ACL tears at the very end. Whenever we suspect an ACL injury, we will usually obtain an MRI of the knee. This picture on the left shows a normal MRI from a normal ACL. You can see these dark black fibers right here. They come down and they're under tension throughout their entire length. They look like they're being pulled very tight. This picture over on the right shows the same type of view, but instead there is this wavy appearance of the ACL and this big ball of tissue at the very top showing where the ACL ruptured from its insertion site. You may be wondering, if we know you tore your ACL, why do we get an MRI? Well, the reason for that is that most of the time when people tear their ACL, they don't only injure their ACL. 80% of people that have an ACL tear will injure cartilage in their knee. About half of people will have a meniscus injury, and somewhere between 30 and 50% will injure one of the ligaments on the outside of the knee. It's important to identify these lesions before we decide on a treatment course because we want to be prepared to address them if necessary. We talked about meniscus repairs before. One of the very important considerations with a meniscus repair is the highest success rate on a meniscus repair occurs at the same time as an ACL reconstruction. If you have to have an ACL reconstruction and a meniscus repair, ideally this would be done at the same time and requires special instrumentation. We want to be prepared for that. So, who do we operate on when they have an ACL injury? The simple answer is physiologically young, active patients who feel unstable. We don't go based on your age, we go based on your overall activity level. For instance, if you are a 65-year-old marathon runner, your ACL is probably pretty important for you. If you are a 40-year-old couch potato, you may not care about your ACL as much. We take all of these factors into consideration in deciding what to do. Some of the scenarios where we would not operate on an ACL injury is a sprain or a partial thickness injury, very low demand patients, people that may have torn their ACL but have no instability. We call these copers. There's a couple of high profile NFL athletes that had bilateral ACL injuries but had no instability and had very successful careers, and patients that have late arthritis in their knee. Whenever we do surgery on an ACL, we are unable to repair the ligament. Instead, we have to reconstruct the ligament. There are a couple exceptions to this, but in general, that's the rule of thumb. When we look at tissue to use for the reconstruction, we have four of the most common graft options here. The first is using part of your quadriceps tendon, which is shown here. The patellar tendon, or what's called a bone tendon bone graft, is sometimes used. And the hamstrings are sometimes used to reconstruct the ACL. The fourth option is an allograft, which is another word for cadaveric tissue. When we decide what type of graft to use, we have to tailor this to each specific patient. We consider multiple factors like your age, your activity level, your profession, how big of a graft we want, and how strong a fixation we want. We also have to consider how patients are going to do in their recovery. Some graft options are more painful and harder to recover from than others, and these all need to be considered. One special consideration I'd like to bring your attention to is using autograft or tissue from your body versus allograft or cadaveric tissue. This graft over here on the right shows the rate of re-tearing your ACL relative to your age. This dotted or broken line at the top shows a cadaveric graft, and the two lines at the bottom show tissue that were taken from the patient. In very young people, let's say a 15-year-old, if you used a cadaveric graft, you would have a 30% chance of re-tearing your graft compared to maybe an 8% chance if we used your own tissue. For this reason, we try and avoid using cadaveric tissue in younger patients. But if you're in your 40s, the risk is relatively unchanged. So a cadaveric graft may be a very good option if you're in your 40s. The next ligament injury we're going to talk about is a PCL injury. This is the ligament that sits just behind the ACL. It's much less commonly injured, or it's much less commonly injured. It is most often injured during either a dashboard injury or a forced kneeling where your knee is bent and your toes are pointing down. In all of these cases, something is forcing your shin bone or your tibia backwards relative to the femur. You may say, okay, so you have a PCL tear, now what? Most of the time, nothing needs to be done. Most PCL tears don't necessarily result in instability or poor function. Even in professional athletes, most of them are able to return back to play at the same level without any restrictions. Physical therapy in the setting of a PCL injury is very important, and there is a very small risk of increased arthritis in the setting of a PCL injury. Next, we are going to talk about MCL and or medial collateral ligament and lateral collateral ligament injuries. We generally divide these up into the low-grade or partial thickness injuries and high-grade or full-thickness injuries. Low-grade injuries are much more common. These often occur during sports like racquetball, where you stretch the ligament but don't fully tear it. There is excellent healing potential in partial thickness injuries to the MCL and LCL. They rarely require surgery, and most of the time, if braced appropriately, people can get back to doing the things they enjoy within a matter of weeks. High-grade or full-thickness tears most often occur in the setting of another ligament injury like the ACL or a multiligamentous injury, and these will sometimes require surgery. The last of the ligament injuries is what happens if you tear multiple ligaments at the same time. This is a very devastating high energy injury. If you tear both of the cruciate ligaments at once or any of the 3 ligaments in the knee, this is the same thing as a knee dislocation. This is usually an emergency. It's considered a limb-threatening injury, and the rate of arterial or nerve injury is quite high in this. Next, we're going to shift locations in the knee. We're going to move to the front of the knee. The first thing we're going to talk about is anterior knee pain. Anterior knee pain has been called many different names in the past, including patellofemoral syndrome, patellar maltracting, and runner's knee. It's a generic term that describes pain in the front of the knee. This is a very common complaint in a knee surgeon's office. It most commonly affects adolescents and young people, but it can occur in anybody of any age. Women tend to be more commonly affected than men. And this is characterized by pain in the front of the knee, which is worse with prolonged periods of immobilization. We often call this a theater sign. This describes a scenario where maybe you go to a movie theater or a stage production and you're sitting for an hour or 2 hours and you start to feel achiness in the front of your knee that gets worse immediately after standing up. This is sometimes accompanied by swelling, but when it does swell, this is fairly mild. We don't fully understand the pain-generating process with anterior knee pain. Several different theories have been suggested, and it may be one of these, it may be all of these. We also know of several predisposing factors, things like muscle weakness, poor core strength, kinetic chain imbalances, all contribute or increase your risk of developing anterior knee pain. To help understand this process, I want you to take a look at these pictures. Let's start at the middle picture here. This is an idealized knee. The kneecap is sitting right here. The end of the thigh bone or femur is sitting right here, and there is this saddle-shaped recess in the femur that your kneecap sits in. Under ideal circumstances, your kneecap will sit right in the center of that saddle recess, and the force that goes through your knee will be evenly distributed throughout the entire articular surface. If your kneecap sits slightly off to the side, you'll instead have a much more narrow or smaller area for that force to be transmitted. And that creates softening of the cartilage and gentle wear and tear. Some important things to understand about anterior knee pain is that for the most part, this is a benign process. It generally does not cause worsening damage to the knee, although it can cause some cartilage softening. And activity, although sometimes painful, is not going to make the damage worse. In fact, the more active you are, the more physically fit you are, and the stronger your quadriceps muscles are, the better anterior knee pain gets. Along the same thread, we're going to go into patellar instability. This is a case where your kneecap displaces or dislocates from its saddle groove and sits out on the outside of the knee. If you look at this picture over here, there is a lump on the outside of this patient's knee showing his displaced patella or kneecap. Patellar dislocations almost always occur laterally, meaning that they almost always move in this direction. 95% of them will spontaneously reduce. You may never actually see your kneecap sitting out of place. In the setting of a patellar dislocation, swelling occurs very quickly, similar to an ACL, and often this has a similar presentation and mechanism to the ACL injuries. Just like ACL injuries, this is more common in females than it is males and happens in younger patients more often than older patients. There are 16 different anatomic risk factors that contribute to patellar instability. We're going to talk about a few of those. This first picture over on the left shows that familiar view of the knee that we saw at the beginning. The quadriceps muscle is here, the patella or kneecap is here, and the patellar tendon is down here. Most of us have just a few degrees of what's called valgus, or knock-knee alignment of our knees. This is how we're built. If you remember all the way back to your high school physics class, there is a vector force that is transmitted through the knee that wants to pull the kneecap out or laterally. If we look at that same view that we saw earlier, the force that wants to pull our kneecap out is in black, and the force that wants to keep our kneecap in is in white. In this view, that is the bony congruity of that saddle-shaped recess. The deeper the recess, the more congruent, or the more force that keeps our kneecap in. The next contributor is a ligament on the other side of the knee called the MPFL, or medial patellofemoral ligament. That acts as a check rein that holds our kneecap in when the forces try to pull it out. If we combine all of these forces together, we get a diagram that looks like this. The first time you dislocate your kneecap, this ligament becomes torn. This happens in virtually 96% of patellar dislocations. And the forces that are helping to correct the alignment of our kneecap are suddenly shifted, and the forces that allow us to pull the kneecap out become greater. That's why once you dislocated your kneecap for the first time, it becomes much more likely it'll happen a second, third, and fourth time. We talked about the congruity of that saddle recess before. This is showing a normal trochlear groove or saddle recess. This view over on the left side shows something called trochlear dysplasia. Instead of having a saddle shaped, it has a rounded edge. It becomes much easier for the kneecap to fall off that ledge without that normal recess. When patients have a patellar dislocation, if it's a simple dislocation, meaning that it happened for the first time and nothing else inside the knee was injured, this is typically treated with physical therapy, which focuses on quadriceps and core strengthening. Sometimes we will use a special brace called a J brace, although this is a little bit of a double-edged sword. Surgical management is considered in patients who have dislocated multiple times, or have high-risk anatomy, or during their dislocation, they injured part of the cartilage surface or potentially fractured a portion of the kneecap, shown here. If this was left alone, this would result in severe arthritis, and this can be addressed, and that fragment could actually be put back into place and secured if it's recognized early enough. Whenever we consider surgery for patellar instability, there's multiple different procedures that are considered. The first and the mainstay of patellar instability is to reconstruct that ligament that tore the first time the patient dislocates. The second procedure is to correct the position of the patella, that's shown here. If the kneecap sits too high, we can move its position further down. If the kneecap sits too far laterally, we can move its position medially. We have the ability to correct multiple different anatomic factors with one or two procedures when it comes to patellar instability. A much more rare procedure is called a trochleoplasty. That takes that flat and round trochlea and creates a deeper groove that the kneecap can sit in. Don't we all sometimes feel like this? The next and last of the injuries we're going to talk about are cartilage injuries. To illustrate this, we put three pictures up on the screen. On the left is that normal arthroscopic view that we saw earlier. There's healthy cartilage on the end of each bone, and the meniscus is of good quality. The middle image shows a focal cartilage defect. It has this very geographic appearance where the cartilage has been completely lost in the center portion, but there is healthy cartilage all around the periphery. The third is an arthritic knee. In this case, there has been similar cartilage loss, except there is no healthy rim. The bone has changed shape and become remodeled, and there is damage to the cartilage both above and below the joint. There's also severe damage to the meniscus. Unfortunately, in the setting of arthritis, we're unable to do anything to try and stimulate or heal the cartilage injury. So when we talk about the focal cartilage injuries, treatment, it depends on size, location, depth, the age of the patient, and other injuries like a meniscus tear or what we call a kissing lesion, like we saw over here. In an arthritic knee, treatment is typically activity modification, anti-inflammatory medications, injections, sometimes we'll brace these, and in some cases, a knee replacement. The next couple of treatments that we talk about are going to focus on this scenario. The first of these treatments is something called a chondroplasty. In this procedure, we are using a small mechanical shaver to remove frayed pieces of cartilage. The second is called a microfracture. In this procedure, we are making small holes in the bone underneath the cartilage. These holes communicate with the bone marrow, and the idea is that stem cells from the bone marrow are allowed to migrate into the cartilage defect and potentially fill that in. This picture illustrates that process. The defect in the cartilage is a lot like a pothole in the road. These little holes are made. Blood is able to come up through those holes and creates a blood clot that sits inside the defect. And the normal motion of the knee over time smooths that defect out, and it turns into something called fibrocartilage or scar cartilage. Although this is similar to normal articular cartilage, it is not as robust and doesn't last as long. Sometimes we're able to fix a cartilage defect like what we talked about in patella. This requires a single large fragment of cartilage to be broken off, and there has to be a very thin layer of bone still attached to the cartilage. But in this case, we're able to put that cartilage back down and secure it with these headless compression screws, preserving your normal healthy cartilage. The next treatment is something called an osteochondral allograft transfer. It's also called an Oates procedure or a mosaicplasty. This is something that we don't do as often now. What is done is bone plugs from a less important part of the knee are harvested, and they're moved to a more important part of the knee to fill a cartilage defect. This is a very effective treatment. The problem is it's a little bit like stealing from Peter to pay Paul. Patients often have complaints and pain where we took the hardest tissue from when we transplanted. The next two are the more modern approaches to cartilage injuries. The first one is called an autologous chondrocyte implantation or an ACI procedure. This is a two-staged surgery. The first stage, we do an arthroscopy and harvest healthy cartilage from your knee. That Cartilage is then sent off to a lab where they grow more cartilage from it. They send it back on this small flexible wafer here. And then you have a second procedure where that cartilage is implanted back into your knee. It's a very effective procedure. This first image shows a knee with a large defect before the procedure is done. This image shows after a debridement of the unhealthy cartilage, and it is then transferred on. And this third image is 6 months after the second stage, when new healthy cartilage has grown in. Although this works quite well, it's a fairly long recovery because it requires multiple different surgeries. The next one is a single stage surgery, and this is my favorite treatment for this problem. This is a product called De Novo, and what it is a allograft or cadaver tissue where healthy cartilage from very young organ donors that died before the age of 13 is used. We take that healthy cartilage and we transplant it into the defect. The reason why we prefer to use younger tissue is illustrated by this picture up on the top right. All of these small little black watermelon seed looking structures are cartilage cells. They're very actively growing more and more healthy cartilage. If we compare that to the image down here from an adult, we see there are far fewer cartilage cells and they're a lot less active. The younger the tissue, the better potential it has to grow new cartilage. The unfortunate truth about cartilage damage, at least right now, is that once this process starts, it's irreversible and cannot be stopped. There's a very complex cascade of events that occurs that starts out with trauma to the cartilage and leads to damage and degradation, ultimately leading to arthritis. I have run out of comics of the knees, so I'm including pictures of my kids. This is my daughter Ella and our family cat Jasmine. They are playing Frozen. Ella is Princess Anna and Jasmine is Queen Elsa. All right, so now we're going to go into biologics. So before we talked about cartilage injury, I said that it's an irreversible process. The promise or the potential of orthobiologics is to potentially change this. They have the potential of helping us slow damage, regrow tissue, and encourage or augment healing. There's several different treatments that are currently on the market, things like PRP and stem cells. We just talked about tissue and cartilage scaffolds. There's a couple of investigational treatments that we're going to discuss, and then some stuff that's coming down the road. In order to really understand the power of biologics, we're going to go through this picture that's illustrated on the right. So I'd like you to think of an injury that happens. Let's say that you cut your finger. It's a deep cut and blood vessels are broken during this process and you start to bleed from that wound. As the blood comes out of the wound, these very small cellular structures called platelets are released. The platelets recognize that they're no longer inside blood vessels and they become activated. They undergo a process called degranulation, where they spill out the contents that are inside them. And this carries with it several different healing chemicals and growth factors. The most important of these effects is to create something called a fibrin clot, which is shown in this picture. It creates this spider web type structure, which creates a net, which captures red blood cells and helps to clot the wound and literally prevents us from bleeding to death. This powerful healing is harnessed using biologic treatments. So the first one we're going to talk about is PRP. So PRP is obtained by taking blood, it's placed into a centrifuge, and it is spun until all of the different elements of the blood have been separated. The heavier red blood cells collect on the bottom, the very light plasma collects on top, and the platelets are sitting right here in the center. Those platelets are full of all those healing chemicals that we call growth factors. A couple of them are listed here. All of those different factors have the potential to increase new cell growth, decrease the signals that tell cells to die off, and minimize inflammation. Multiple different studies suggest that PRP can be helpful in several different orthopedic injuries. Things like tennis elbow or patellar tendonitis, Achilles tendonitis can all be very effectively treated with PRP. And it's also an adjunct to surgical treatment for cartilage injuries. PRP can be helpful at improving the pain of arthritis, but it does not reverse or delay the progression of arthritis. The next type of treatment we're going to talk about is called amnion-derived allograft. Even though this has the word amniotic in it, it is not a stem cell treatment. What this does is uses the cell wall of a placenta with all of the immunoprotective tissue and the growth factors and the anti-inflammatory components, and we can inject this into tissue that has been injured. It works very similar to PRP, but it doesn't require your own blood. It has a very similar effect in the ability to treat conditions like ligament injuries, tendon injuries, tendinitis, and can be helpful at helping wounds that don't want to heal. There are some limited human studies with this, and it shows that it tends to work on the same things that PRP works on. Amnion-derived allograft and PRP are very similar in their effects, but the difference is in how insurances view them. PRP is almost never approved or reimbursed by insurances, but amnion-derived allografts can be. The next treatment is stem cells. There's multiple different sources that we can obtain stem cells. We can use bone marrow, like we talked about in a microfracture. We can use fat cells from our own bodies, or we can use placental or umbilical cord tissue. The idea with stem cells is we have these cells that have not yet decided what type of tissue they want to become. They could potentially become nerve tissue or muscle tissue or cartilage. And if you give them the right environment and stimulation, that will drive them in the direction that we want them to be. So in theory, you can take stem cells and make anything else out of them. But this process is not fully developed or understood at this stage. We have seen some preliminary improvement with stem cell treatments in injuries like rotator cuff repairs or tendon injuries like tennis elbow. And it can be a potential augment for intra-articular cartilage injuries or meniscal injuries. But we have not seen any distinct improvement if you simply inject stem cells into a joint. The next is something that is not widely available, but may prove to be helpful down the road. It's a chemical called alpha-2 macroglobulin. To understand this, we're going to go back to that same flow chart that we talked about earlier. And one of the results of this cascade of inflammation is our body creates these enzymes called matrix metalloproteinases. We call them MMPs for short. MMPs are an enzyme that helps to break down cartilage and the bone immediately under cartilage. When these are released into an injured joint, they help to hasten or speed the process of arthritis. Alpha-2 macroglobulin is a protein that is normally circulating in our blood. In low concentrations, it acts as a very mild natural blood thinner, but in high concentrations, it deactivates those enzymes that break down our cartilage. This is also found in PRP and amnion tissue, which may explain why A2M treatments can reduce inflammation and ease some of the pain associated with arthritis. The last thing I want to talk about is what may be coming down the road. These two pictures show a sea star and a salamander. Both of these animals are known for the miraculous ability to lose an entire limb and regrow that limb. They can do this because their DNA has genetic code for something called blastema regulation. Humans have the same DNA, but we don't have the key that unlocks the DNA, or so we thought. Last year, some cell biologists found the key to unlocking this DNA in cartilage in the ankle of humans. We do not see this in the knee or the hip, and this may explain why the ankle is more resilient and has a greater ability to heal from arthritis. If we were able to unlock this DNA, we may be able to prevent or avoid damage to the knee before it has really had a chance to take hold. I think that's pretty cool. That is the end of my presentation.